We now begin Lecture 32, Limb Development. And first we take a look at two illustrations of the embryo, lateral views, days 18 to 21 and days 27 to 30. So from the second week through the third week and through the fourth week and so forth, fifth week, we see that we go from a state of no apparent limb development to full forelimb and hind limb development, at least to produce the limb buds. So there is a forelimb bud and a hind limb bud. And of course, the rostrod or cephalod end of the embryo is growing much more rapidly than the caudad. So we'll see there's a couple of day lead for the forelimb over the hind limb. At days 31 to 34, we see that we have a rather distinctive shoulder, arm, forearm, and hand developing. We also see that there's a depression in between the digits and a continuous ridge at the tip of the digits. So something's happening here to create the digits of the hand. And we note that the forehand excels in its development versus the foot or the hind limb. Here we see day 44, and again, most prominently in this lateral view of the embryo, we can see the digits as little bulges, so something is happening here. And in the hind limb, we do not have those digital appearances as yet, but we can see a nice shoulder, arm and forearm, wrist, hand, and early digits, and as well a hip, the thigh, the leg, the foot at the ankle here, the foot, and then we know that the digits will appear here. And we see in this MRI, three-dimensional reconstruction, that there is a web between the digits. So something is happening where there will be a digit and where there will not be a digit to change the thickness of the underlying tissue. Here at 2 months, we can now begin to see that there's a flattened portion of the hind limb, and so the digits are just starting to appear there, and we can see very distinctive digits in the forelimb, the hand. So this is at 47 days, 7 weeks, or about 2 months. So the development of the appendicular skeleton is from chapter 15, figure 1515 is what we'll consider. And of course it consists of the two girdles, the pectoral girdle in the shoulder region and the pelvic girdle in the hind limb region. And then there will be the limb bones. The cartilage will form a model first, and that is appearing in week 6. And then ossification will occur, and it is always proximal to distal, beginning about week 8. So in the fetal stage, we get ossification. So here's figure 1515 of an embryo, about 28 days, and showing the early appearance of the limb buds, and we see some features of the forelimb here. There's a surface ectoderm and underlying loose mesenchyme that has moved into this area, and there's an apical epidermal ridge. So there's obviously something going on here to trigger these events. In panel C, we have a sketch of the upper limb about 33 days, so about 5 days later, and the mesenchymal primordia of the limb bones is apparent. The digital rays are mesenchymal condensations that undergo chondrification and ossification to form the bones of the hand. And then in D, we're going to look at the upper limb at about 6 weeks, showing the cartilaginous models of all the bones, and we'll point those out. And then later in the 6th week, shown here in panel D, there's a tremendous change that occurs, and we'll have complete cartilaginous models of the bones of the upper limb. So here in panel C, then, we see the mesenchymal primordia of the forearm bones. This is going to be the thumb side and the pinky side, so the radius and the ulna. And we see the digital rays of mesenchymal condensations beginning to appear as well. In panel D, we now see the bone of the arm, the humerus. So this is also called the brachium and the antebrachium, the arm and the forearm, respectively. So we see the radius and the ulna. The cartilaginous model is there. The carpal cartilaginous models are just beginning to form, as well as the rest. And then later in week 6, there is the full cartilaginous model for the scapula, the humerus, the two forearm bones, the radius on the thumb side, and the ulna. The carpal bones are beginning to appear, as are the metacarpals and the phalanges. So here we see at 8 weeks the fetal stage. With the reverse lighting, we can see these cartilaginous models, and the ossification centers are actually beginning to appear as well. So the wrist bones are fully developed, as are the metacarpals and the phalanges. And we can see the thumb, the first, second, third, fourth, and fifth digits. And the bones of the forearm here, we see the letter W with the tip of the arrow at the forearm bone on the thumb side, which would be the radius. And then at 34 weeks, very close to birth, we can see that the upper extremity is fully developed and completely recognizable. So I'm not sure what type of surgery was being performed on this fetus, but we can see that vascularity would be accessible to infuse certain things and a variety of things like that. So we see the shoulder, the arm, the elbow, the forearm, and then the digits, 1, 2, 3, 4, 5. Continuing with an overview then, we can refer to figure 17.3. The limb buds appear during week 4. The upper extremity about 2 days before the lower extremity, and there is a core of mesenchyme from the somatic layer of the lateral mesoderm that is covered by the ectoderm, of course. And the ectodermal thickening, that apical ectodermal ridge that we saw, or AER, is at the apex of the limb buds, and it induces the limb growth and development. So a tremendous amount of chemical signaling. So the distal ends flatten into that paddle-like hand and foot plate, and during week 6, the hand plates form the digital rays. About 1 week later, for the foot plates, and then the limbs have the cartilaginous models, as we saw. The digits will be formed by 8 weeks. We saw that in the photograph. And the ossification begins in week 7. So we were seeing some of the ossification centers in that view with the reverse lighting, where we saw the radius bone labeled. So the web between the developing digits is removed by the process of apoptosis, also called programmed cell death. So this is a mechanism of cell death that does not trigger an immune response. So macrophages, these phagocytic cells, will not move in and produce any type of inflammatory or immune cell response. So the cells are basically destroying themselves and cleaning the area without triggering any type of a response. Pre-programmed cell death is another correct answer here. So either of these two would be correct, but let me go on to say pre-programmed cell death is the term most appropriate for this type of apoptotic cell death. Apoptosis does occur in adulthood, like the lining of our intestine, and with some neurodegenerative diseases. So the pre-programmed cell death is the best possible answer to this question, because it is the term for an apoptotic cell loss in the embryo and fetus, if it occurs. So now we can talk a bit about the muscle compartments that will develop. The dorsal muscular compartments will always contain the extensors, and the ventral muscular compartments will contain the flexor muscles. Now the limbs rotate, so this is a bit different, especially for the lower extremity. So we'll point that out as we go along. So there is a rotation during week 7. We'll see this in figure 17.8. The upper limb will have a lateral rotation about 90 degrees on the longitudinal axis, and the lower extremity will have the opposite, a medial rotation of about 90 degrees. And this creates the adult human appearance as we know. So figure 17.8 is going to show us in panel A a lateral view of an embryo at Carnegie stage 21, about 52 days. Fingers will be completely separated as we know. The toes are beginning to separate, and we'll see the feet are fan-shaped. And then in panel B, there'll be a lateral view of an embryo at Carnegie stage 23, about 4 days later. And then all the regions of the limbs are apparent, and the digits in the hands and the feet are separated. So here we see complete separation of the digits, the fingers. The elbow is pointing posteriorly, so we've already had some medial rotation, lateral rotation of the upper extremity, and the knee is facing a little bit ventrolateral, so we've had some medial rotation of the lower extremity. And then here we see that medial rotation of the lower extremity is even greater. The knee is now taking on nearly an anterior position, complete opposite of the elbow, which has its posterior presentation. So the lower, the feet should completely rotate, and of course the plantar surface, the bottom, will be planted on the ground, and then the hands will have a different orientation facing anteriorly in anatomical position. So the lower extremities rotate 90 degrees, medially during the medially 90 degrees. So all we need to know is that, and then we know that that's during the days 41 to 49. So now we can talk a little bit about the innervation of the extremities. So the motor innervation enters from the spinal cord at about week 5. At the same time, some of the myotome mesenchymal cells are going to migrate into the extremity, the mesenchyme of the extremity, and differentiate into myotubules, the precursors of the skeletal myocytes. And they'll pick up their motor innervation as they move away from the spinal cord and carry it with it. The sensory innervation will jump onto those motor nerves and move right along with it to innervate the muscle target cells, and then continue to migrate in to innervate or provide the cutaneous sensory innervation of the extremities. So sensory of the peripheral nervous system we know is neural crest origin, and it gives rise also to the Schwann cells that surround and support all of these nerve fibers in the peripheral nerve, whether it's myelinated or unmyelinated, but it definitely is responsible for producing the Schwann cells that form the myelination of the peripheral nerves, both the motor axons and the sensory fibers. And dermatomes, these are slices or toma of the skin, the derma, that represent this cutaneous sensory innervation, and that will develop during week 5 as well. So as the motor innervation goes in, the motor sensory innervation goes with it, as well as the cutaneous sensory innervation. And we'll look at figure 1710 to look at that dermatome development in just a moment. So this is an illustration that we saw earlier. So the neural tube is developing here dorsally. The neural crest cells are dorsolateral to it, and we can see some of the lateral mesoderm in this area. This would give rise to the myotome, and then some of these myotomes will excuse me, the uh, the myotome mesenchymal cells will migrate into this area and differentiate into myotubules, and the motor innervation will go along with them and come out the ventral part of the spinal cord. Will go along with them, and then these neural crest cells will migrate with them to produce both the motor innervation and the cutaneous and the motor sensory information. So the neural crest cells just migrate into this area or send extensions of their sensory neurons into this area. So this is figure 1710 from the textbook, and it's showing the upper extremity in panels A through C and the lower extremity in panels D through F, and we're looking at the dermatome development. So the human organism is segmental, especially at this early stage. And what we see is that with the upper extremity, the seventh cervical nerve innervation will form the axis of this structure. So there will be things before that and after that. So a preaxial border and a post-axial border are created. As we progress to panel B, we can see that there is a ventral axis line where the seventh spinal segment, cervical spinal segment, sensory innervation, is pushed to the distal end of the limb bud, leaving a point where the preaxial and postaxial dermatomes come and join each other. So there's not very much overlap here, but there will be overlap in sensory innervation between the corresponding spinal segments, cervical 3, 4, 5, 6, 7, 8, and thoracic 1 and 2. And then in panel C, we see the adult version of this. C3 is near the shoulder, C4 moving out into the arm, C5 the arm and the lateral forearm and posterior forearm, C6 right near the ventral midline of the arm onto the thumb, C7 getting most of the palm and the dorsum of the hand, and digits 2, 3, and 4. Digit 5 would be C8. Then we see first thoracic is the medial part of the ventral forearm and the dorsal, as well as proximal of the arm, T2. Then with the lower extremity, we see the lumbar spinal segment 2, 3, 4, 5 represented here, and then the sacral spinal segments innervating the postaxial portion of the lower extremity, S1, 2, and 3. So the myotomes are quite similar to this. It's offset a bit because the muscles are distributed differently, but it's the same type of segmental innervation. Because remember, they migrate into these areas together, both the sensory and the motor, and both motor and cutaneous sensory innervations. We see we end up again with a ventral axial line, and so it ends up becoming dorsal because of the rotation of the lower extremity. And we see L2, 3, 4 are the preaxial, L5 is right at the axis, S1, 2, and 3 are post-axial innervations. And so we see in the adult, the S1 is at the heel of the foot and the lateral foot. L5 is the mid portion of the foot, and then L4 is the medial portion of the foot, extending into the medial calf and the medial thigh. So what we see is that L3 and L4 go from a superior position to a medial position with that medial rotation at 90 degrees of the lower extremity. So the dermatomes of the preaxial upper extremity are innervated by the spinal segments of the cervical spinal cord. So we saw that in this slide, preaxial, cervical. So now we can take a look at the blood supply. This will be from figure 1711 in our textbook. it's supplied by branches of the intersegmental arteries. So remember these intersegmental arteries coming off the cardinal arteries here. So the anterior cardinal artery would be supplying an intersegmental to the forelimb, and the posterior cardinal artery supplying one to the hind limb. So here we can see the forelimb development. There would be an intersegmental artery coming directly off the aorta later in development, and it will have connections with the developing vasculature within the mesenchyme of the upper limb bud. There's always a proximal to distal development in these. So the proximal is developing more, not necessarily rapidly, but it becomes established in its development earlier on because the proximal portion has been there longer. Let's put it that way. Because there's very rapid mitotic cell division, mesenchymal cell division at the tip or the distal end of the limb bud. So a vascular complex is formed within the limb bud, and certain arteries will develop from that. We see that there is a primary axial artery that connects the intersegmental artery into this area. We end up with a brachial artery in the arm. At the elbow, there would be a branching of the ulnar artery and the common interosseous artery. The common interosseous artery will be the one giving blood supply to the hand, this plexus within the hand. And then the median artery will branch off that common interosseous artery. And as we proceed, we see again the brachial artery. The radial artery will develop from that. And then there will be the anterior interosseous artery that will have developed, and we see the median artery coming from that and giving the general blood supply to the hand. So this will change over time. The ulnar artery is beginning to develop as well. And then this will lead to the adult situation where the brachial artery will be medial to the humerus, cross anterior to the elbow joint, and then divide into the radial artery. And the common interosseous artery will be here as well. They're not really showing it. And the median artery will branch from that. The anterior interosseous artery, there's also posterior interosseous artery that we can't see, and the ulnar artery. So we see that the ulnar artery moves in to take control over providing primary blood supply to the medial aspect, near digit 5, of the palmar arterial arch, or the blood supply to the hand, and then the radial artery will give blood supply to the lateral portion. So the venous system develops similarly, but the venous system has superficial and deep veins, and we're not going to take the time to go over that material. Now for the hind limb, we see that there's the common iliac artery coming off the aorta and the external iliac artery. And remember, the umbilical artery contributes to the common iliac artery and feeds into the common iliac artery, I should say. Doesn't feed into it, it branches off it. Sorry about that. And the external iliac artery is going to give rise to the femoral artery. And then there will be a primary axial artery of the hind limb with this plexus forming in the most distal portion, which we know is going to be the foot. So this proceeds to develop two main vessels, the femoral artery and the deep artery of the thigh, profunda femoris artery, and they are giving common supply into this popliteal artery that will give rise to the posterior tibial artery. And then we have an anterior tibial artery there that isn't labeled, but at present we're seeing two common inputs to these, and then this will go on to further develop so that there's an ischiatic artery, and then the femoral artery will be the primary supply for the popliteal artery, with an anterior tibial artery that develops, a fibular or peroneal artery, and the posterior tibial artery coming in to give the main arterial supply to the plexus, the arch within the foot. And then this leads to the adult, where the deep artery of the thigh will come off the femoral artery. So this is the profunda. The femoral artery will migrate medially and pass posterior to the knee joint and through the popliteal fossa, so it's called the popliteal artery. It will give rise to the anterior tibial artery. As well, it will give rise to the posterior tibial artery, and we see the fibular artery branching here, or the peroneal artery. The posterior tibial artery will continue on to the foot, giving rise to the lateral plantar artery, giving main supply to this vascular arch in the foot. And then there will be a medial plantar artery going over toward the toe, the first digit of the foot. So here we see the reverse illumination of a fetus, and we can identify some of these vessels. So we see the femoral artery in the thigh passing medially, rotating and coming posterior to the knee. So this letter Y would be pointing to the popliteal artery, and it gives rise to the posterior tibial artery that we see here. So this is the ankle, so we're still above the ankle, so this is posterior tibial artery at Z, and then it continues on as the medial plantar artery. So we see the big toe here, so we know we are medial, so that's the medial plantar artery, and we see the medial plantar artery going over to the big toe. From the lateral view, of course, we are getting to see the lateral plantar artery labeled at letter X here. So there is the posterior tibial artery, and the lateral plantar artery comes off that. So let's consider some limb abnormalities. There's a critical period of development, 24 to 36 days after fertilization. It's the most well-known teratogen is and was thalidomide. It is coming back into use in modern times, but not for childbearing women. And it was used as a general relaxant, let's say, and anti-nausea agent. So it was used to treat morning sickness, which is very early, and would prevent, as a teratogen, it would prevent the development of the extremities to different degrees. So other causes are usually genetic, such as polydactylia, which is producing extra digits. So this is autosomal dominant, and it is common among the Amish. Syndactyly is another one, the webbing of the digits. So now we can work through a couple of the clinically oriented problems. So case 17-1, a mother consulted her pediatrician after noticing that when her 11-month-old daughter began to stand independently, her legs seemed to be of different lengths. Do more female infants have congenital dislocation of the hip than males? That's yes. Are the hip joints of these infants usually dislocated at birth? No. What are the probable causes of congenital dislocation at the hip? So the number of female infants with dislocation of the hip is approximately 8 times that of male infants. The hip joint is not usually dislocated at birth. However, the acetabulum, within which the head of the femur fits, is underdeveloped, so it can slip out rather easily. So this dislocation may not become obvious until the infant attempts to stand up several months after birth. And this condition is probably caused by deforming forces acting directly on the hip joint of the fetus. Here is case 17-2. A male infant was born with limb defects. His mother said that one of her relatives had a similar defect. Are limb anomalies similar to those caused by the drug thalidomide common? What was the characteristic malformation syndrome produced by thalidomide? And name the limb and other defects commonly associated with the thalidomide syndrome. So several anomalies of the limbs: amelia, lack of development; meromelia, abbreviated development, so they're shorter, similar to those produced by thalidomide, are rare and usually have a genetic basis. The thalidomide syndrome consisted of absence of limbs, amelia, Gross defects of the limbs, the meromelia, such as the hands and the feet attached to the trunk by small, irregularly shaped bones. There's intestinal atresia and cardiac defects. Here's case 17.3. So a newborn infant was born with an obvious club foot. The physician explained that this was a common type of anomaly. So what is the most common type of club foot, and how common is it? And describe the feet of infants born with this anomaly. So the most common type of club foot is Talipes equinovarus, occurring in about 1 of every 1,000 newborn infants. In this deformation, the soles of the feet are turned medially, and the feet are sharply plantar flexed. So the feet are fixed in the tiptoe position, resembling the foot of a horse, the equinus. So that's the equinovarus portion that we see there. Case 17.4, a baby was born with webbing between the fingers. The doctor stated this minor defect could be easily corrected surgically. Is syndactyly common? Does it occur more often in the hands than in the feet? And what is the embryological basis of syndactyly? So syndactyly is a fusion of the digits. It's the most common type of limb anomaly. It varies from cutaneous webbing of the digits to synostosis, a union of the phalanges, the bones, the ostosis. The syndactyly is more common in the foot than in the hand. The anomaly occurs when separate digital rays fail to form in the 5th week, or the webbing between the developing digits fails to break down between the 6th and the 8th weeks. As a consequence, separation of the digits does not occur. So this completes our discussion of development of the limbs, Lecture 32.